I'm Dr. John Stewart, Associate Professor of Surgery, Section of Surgical Oncology at Wake Forest Baptist Health. It is estimated that 123,000 Americans will be diagnosed with malignant melanoma this year. Fortunately, most people are diagnosed in the early stages. Thus, approximately 800,000 Americans have had a diagnosis of melanoma at some point in their lives. Melanoma is most deadly when it is caught at the latest stages, i.e. when it is spread to the lymph nodes or other parts of the body. Unfortunately, up until very recent history, there have not been effective treatments for metastatic malignant melanoma. Moreover, there has not been effective treatments for patients who have had spread to the lymph nodes at the time of diagnosis. So the vast majority of patients with melanoma are treated with a surgical excision, and depending upon the depth of the melanoma, they have their lymph nodes evaluated by what's called a sentinel lymph node biopsy. A sentinel lymph node biopsy is a significant advance in the treatment of melanoma, whereas 20 to 30 years ago, all individuals with melanoma had all of the lymph nodes taken out from the draining basin, whether it be from the armpit or the groin. Now we're able to identify the sentinel lymph node by using radioactive tracers and blue dye that is injected into the lesion. At that point, we can take out the 2, 3, 4, or 5 lymph nodes that are most likely affected by cancer and perform a careful evaluation of those lymph nodes. So once melanoma has spread to the lymph nodes, traditional teaching is that a complete excision of all of the lymph nodes in that draining basin be performed by a surgeon who has significant experience. However, there is some data from the John Wayne Cancer Center in Los Angeles that patients might be able to be monitored with an ultrasound of that lymph node basin to see if they enlarge and subsequently require a completion node dissection at a later stage. Patients who have metastatic disease, i.e. it has spread from the original site of cancer to other parts of the body, have several very exciting options. Traditionally, I've used a drug that's called high-dose interleukin-2, which stimulates the body's immune system, its T cells in particular, and some other parts of the innate immune system, to recognize and kill melanoma cells. However, there have been advances that have been reported that less intense therapies, i.e. those that do not require monitoring in an intensive care unit but can be delivered on an outpatient basis, such as ipilimumab, can also encourage the body's immune system to recognize and fight cancer by downregulating those T cells that would inhibit a good immune response against cancer cells. Up until recently, our survival rates for metastatic melanoma have been very stagnant. However, given the advances in immunotherapy and evaluation of signaling cascades that are effective in melanoma, there's some suggestion that we will have an increase in the survival from this disease. I would say that the multidisciplinary effort to treat this disease sets us apart from many other medical centers in the region. We have a dedicated melanoma coordinator who is charged with understanding patients' needs both in the clinic and outside of the clinic. Our coordinator is also charged with setting up not only surgical options, but also enrolling in clinical trials that are available in the medical center.